Hello, everyone. Welcome to another episode of Disruptive Dental Science. I'm Dr. Matthew Miller, Clinical Ambassador for Dental Advisor. And joining me today is Dr. Taiseer Sulaiman, another Clinical Ambassador with Dental Advisor and faculty member at UNC School of Dentistry, and one of the greatest minds in dentistry that we have today, and just an amazing clinician, a great person. Very thankful to have him on the show and to be able to work with him and be partners with him at Dental Advisor. So Taiseer, thanks for joining me. Today,
Thank you, Dr. Miller. Thank you.
yeah, Taiseer, thanks so much. Today, this is really going to be an area of discussion right up your alley. You know, you're a foremost expert on this. We have a journal coming out in March, early March, from the Dental Advisor about the principles of adhesion and bonding. And I can't think of anybody better than you to have this discussion with, to really kind of talk about some of the things that we have available today, where we've come from, and get your expert opinion on some of these procedures.
Absolutely. Well, thank you. And I'm very happy to be here with you. Always a pleasure to have a discussion with you, Dr. Miller, and especially under the umbrella of Dental Advisor. It's an absolute pleasure. Thank you for having me.
Well, yeah, you're welcome. And so tell us a little bit, you know, with your background. I mean, obviously everybody knows who you are, but tell us a little bit about, you know, your areas of interest, of areas of study. We know you work a lot with ceramics and adhesion and bonding, but in light of our discussion today, tell us a little bit about your background.
Well, you know, I've been practicing dentistry right now for about 20 years. And I always share the story that you know, I think the first half of that, I thought I did good treatment planning. I thought I have okay hand skills. I wasn't really suffering from that. But when it came to material selection and material application, I really didn't have a clue. And you know, this was in an era where there were a lot of materials that were presented to us, and you know, we relied and we were taught mostly to rely on clinical based evidence, right, and scientific evidence before we make the selection of a material, before we learn how to properly apply it. And what I started to realize is that, again, we were bombarded by all these materials with very minimal evidence, and I didn't know what I was doing. I mean, I really thought I was more technical in my restorative approach versus being more scientific in the and that's what makes a true clinician, right? Is that when you combine the science with the experience, and so I kind of just jumped into that world where I was learning more and more about the material science, because if you go down to the roots, I think it gives you a better understanding of what you're dealing with. And that's where my PhD came along. But I really don't define myself as a material scientist. I still rely on a lot of actual scientists to give me the explanation. But I am a very wet-handed clinician that made a lot of mistakes, and my restorative care was not as good as it was today. And it's not because I became more talented all of a sudden. It's just really because I started to understand these materials, which allowed me to select the appropriate material, and most importantly, learn how to apply it. And now every procedure that I do, I go over the steps, and I have a more of a scientific approach, or more of a visual approach to what's actually happening when I'm doing, for example, the selective edge process, or when I'm doing the priming, and when I'm doing the adhesive. It really changed my restorative care for my patients, and I started to see my restorations lasting a lot longer, looking much better, and I rarely have failure because of the material. It could be failure because of, you know, technical or patient issues, but the material is lasting a lot longer. And that's really where my focus has come along, where I'm trying to share this experience with clinicians. And because if you eliminate the knowledge of materials or the technology in your restorative care, that's about half your work. I can't think of a restorative procedure that does not involve a material. And so if you ignore that, then I really don't know how you're going to maximize the restorative care for your patient. And so that's really kind of been the focus over the past years, sharing that experience, having the opportunity, you know, with the laboratory that I have at the school, to just kind of go in and ask the questions that clinicians are wanting to learn, and trying to find a simulated or maximize the clinical relevance of these in vitro studies, and most importantly is translating it from a clinician's point of view in the publication, in the writing. And I think that's resonated very well with whoever's listening or to me speak or reading some of the things that I'm sharing out there, is because I share it from a suffering of everyday clinician, and I'm just trying to help avoid clinicians making the same mistakes that I made.
I mean, that's all so well, that's just very well said. I mean, and we appreciate your contributions to the field of dentistry to really help other clinicians in their journey, and really helping elevate patient care, right? So when we look at, you kind of mentioned a couple of things there, and as it relates to materials and technique, and one of the biggest things you mentioned is that I think that manufacturers have created, in general, most manufacturers have created very superior materials. And it really comes down to the clinician to be able to follow those instructions and use them as indicated, right? Make sure you're not using them for perhaps an off-label use that they're really not indicated for. And that's where you have failures, or if they're not done properly. So I think in large part, where we came from with adhesion and bonding was very technique sensitive. It was exceptional results, but it was very hard to get there. Not very, but you really had to follow that prescription, and not over desiccate or have too much moisture within the tooth surface, or isolation is certainly key. And then some of those materials, they have their own shortcomings and so forth. But nowadays we've got excellent materials to choose from. And one of the things I want to talk about with you is universal bonding agents. Is it, in the past we had these universals, they were okay. They were decent, but now I feel like we've gotten to these 8th generations that have excellent stability in their chemistry. They've got great bond strengths and mechanical properties, and they're easy to use. So when we look at those 4th and 5th generation bonding agents like OptiBond FL or Clearfill SE, and we compare them to modern day universal bonding agents, has that improvement in the technique sensitivity, which reduced user error, resulted in better outcomes? You know what I mean? Like, are we really at that stage where these are the materials to go with?
So that's a very good question. I agree with you with the statement of manufacturers are putting in a lot of effort along with their researchers to develop, the best material, regardless of what it is. And they're trying to make things easier, of course, for the clinician, less technique sensitive and less time. And, I always, without trying to be harsh to the listener, I always say, if you're seeing failure in your practice, if it's debonding or if it's staining of composites, fracturing of composites or ceramics, stop blaming the material. It is not the material's fault. It is really your fault that you just failed to either select the most appropriate material or apply it correctly. And every time I'm in a room and there's some representative from a manufacturer, I always, after talking, they always give me a big hug, trying to say, yes, thank you very much for pointing this out, because we can't say this to the clinician. And we always try to play along with them nicely about, oh, maybe because let's see your steps and et cetera. No, I'll say it as it is. I think that, you shouldn't have these failures. In the area of adhesion, the bond strength quality that we have to the tooth structure, whether it's to enamel or to dentin, is phenomenal. It is phenomenal. It is way more than we actually need. And you're more likely to see fracture at the tooth level versus the adhesive level or the restoration, because of how good these materials have become. Now, what I've found a little bit, I wouldn't say challenging, but when you're talking about the different generations of adhesives, and you're trying to educate the younger generation, the upcoming generation, it's a little challenging with the materials that we have to find strong clinical evidence. And we
Mhm.
can't just rely on manufacturer data or history of, well, we don't really have history on a lot of these materials, but clinical success. A lot of these opinions can be biased opinions, right? And so when we go to the literature and try to find good evidence, it's very hard to find solid clinical evidence on a lot of these materials that we're using. And so now you're really challenged with, do we advocate and push for these new materials, or do we stay with the more classical materials that we do have very good evidence? So again, back to the area of adhesion, when we talk about, you said OptiBond FL, which is the fourth generation, and the SE Bond 2, these two adhesive systems, we have more than 13 years of clinical evidence proving that they are successful. And so we've learned from those studies how to apply them and how to use them. And if you wanted to play it safe, you can't go wrong with them. Either system, they work phenomenally well. Now, when you jump on, see, I'm a strong believer that every adhesive system can work, okay, if they are applied properly. You can maximize the potential of each system,
Yeah.
but it really relies on you understanding how the system was developed and how to apply it. Again, that enables you to maximize the potential. Now, if you were to ask me, is there one that's a little bit better than the other, then I'm going to say, yeah, absolutely, because we have clinical evidence for this one versus this one. And so that allows us to share that scientific and clinical evidence, okay? And so when you, again, something that if you read through the literature and listen to the actual gurus on adhesive dentistry, and these are the people that I rely on a lot. I mean, you got Bart van Meerbig from Belgium. You have George Vertigau. You have people like Ed Swift. You have, of course, Pashley and Tay, the early researchers on this area. When you go back and you read their updates on the more modern, less technique sensitive, less steps, you start to conclude one thing: adhesive dentistry cannot be done quick, and minimizing steps reduces its efficiency. And you just, when you read something like that and you find these different, scientists, researchers, or clinicians that are making these kind of statements, it makes you stop and it makes you really dig into the information, what they're trying to say, and they're absolutely correct. And for example, the fifth generation that was introduced to minimize the number of steps, where they combine the primer and the adhesive together in one bottle. You look at the evidence supporting it, it is not even close to what we had from the fourth and the sixth generation. If you look at the seventh generation, which had the etch, the prime, and the bond all in one system, and this is before the universal or the
Right.
eighth generation, they claim it right now, came out, that didn't do well at all.
No.
And if you ask the question, why is this not working? We're trying to minimize the number of steps. It's less technique sensitive. It should work. Well, you go back again to the chemistry of these adhesives and why. And so, in your writing, you talked about the water trees and the theory about it. And I believe in the water tree theory that was first introduced by Pashley and Tay. And, whenever you have that hydrophobic coat on top of your hybrid layer, it's going to protect it. When you have the primer and adhesive together, you're missing that hydrophobic coat. Now it's hydrophobic and hydrophilic. And now these water trees are starting to develop much easier and degrade your hybrid layer. Once you lose your hybrid layer, your restoration pops off. And so, when you go back to, before we jump into the universal and the eighth generation, you go back to the fifth and the seventh, and you see the clinical evidence that it's not nearly as close as the fourth and the sixth generation. You say, okay, there are clinicians that have been trained on these systems, and they, changing the adhesive for the clinician is probably one of the hardest things, right? And some will say, I don't see these failures, or I don't have these issues. And then you ask them the question, okay, I respect your opinion, but how well do you really follow up on your work? Unless you're actually following up on all your cases where you've flagged them and they're coming back for your the hygiene appointments, and you're looking and you have a data that is confirmed and presentable, then it's hard to say I don't have any issues in my practice, or I don't see any issues. Maybe that patient didn't come back to you. right?
Right.
Or maybe it failed and you forgot that you had placed it just last year or 2 years ago. And so a lot of these issues are really stemming from the chemistry and the nature of the fifth and the seventh generation, where we lost that hydrophobic layer on top. But then you say, okay, listen, if you don't want to change your adhesive system, the fifth and seventh generation, again, that one-step application is probably not enough. You need to raise and the thickness of your hybrid layer. And so all I would recommend for you to do, instead of applying one application, you're going to apply a second application and just air thinning in between the applications. You don't have to cure. And that will, again, give the water trees a harder challenge for degrading the hybrid layer. So in other words, again, that's adding more steps.
Yeah.
So if you
Yeah.
think about it, the fourth, fifth, sixth, seventh generation, they're all done at their best when there's 3 steps that have been followed. Right? Whether it's you're selectively etching the enamel because you're not relying on the self-etch capabilities of the adhesive system. But again, you come to conclude like they're all do much better if you employ 3 steps. So
Yeah.
again, we're back to technique sensitivity
Right.
and adding more steps. And if you wanted me to comment on the universal adhesives, the 2 major changes happened in the chemistry and of the 7th generation. First of all, they realized that the strong acidic primer might have enabled a better etch of the enamel because they want to minimize your steps. They want you to part ways with etching your enamel. However, it was very evil to the dentin because it was acidic, right? And so now you have the same problems as you were with when you're total etching the dentin surface, and now you're removing the minerals, you're exposing the dental tubules by dissolving the smear layer. So the chances of a strong chemical bond, which has evolved over the past couple of decades and really became phenomenal in our modern day practice, and also the sensitivity. You have issues with post-operative sensitivity now. So 2 things that changed that highlighted this generation is going back to more of a mild self-etching primer, similar to what the success that had with the SE Bond 2 system. And that turned out to be more friendly to the dentin. And they just told the clinician, you know what, just do selective etch. If you're really concerned about bonding to that surface properly, just go ahead and we can't part ways with phosphoric acid edge of enamel, period. Okay. And so, but the dentin now has more minerals in it, and the smear layer is partially dissolved, not entirely. So better chemical bond and less post-operative sensitivity. And you know, we do have some evidence. I can't say as strong as the 4th and the 6th generation. We have 5-year follow-ups from Perdigau's group and from Nate Lawson's group as well, where they looked into 5 years for Scotch Bond Universal. And they saw a very good survival rate whenever the enamel was etched versus relying on its self-etch capabilities. So universal adhesives have a mild self-etching primer. You have to combine that with a selective etch and also have the MDP monomer in it because the patent expired from Curari, and now it's been included in many other universal adhesives. And the MDP monomer turned out to be a phenomenal, strong, stable monomer that can really enhance a great chemical bond to the dentin and also to the subsequent resin. And so those are the 2 highlights with the universal adhesives that have been introduced to us.
What are your thoughts on Curari's Clearfill Quick? Right, they've got that rapid amide monomer with that quick uptake. Kind of going back to a little bit of that hybrid layer discussion. You know, something like that. It's pretty innovative. You still have to apply it, right? So I still find, you know, that whether, you know, when I've tried it or worked with it, you know, I still find myself inherently scrubbing, and I'm sure a lot of other clinicians do too. But that's a neat technology that would hopefully mitigate some of that, the issues you have with the hydrophilicity, you know, against the 2 surface. We want it to be hydrophilic so it penetrates, but we don't want that drawing up, you know, the water trees from the dental tubules within. What are your thoughts on that?
You know, I think again, going back to the hard work that the manufacturers and the researchers have put in these universal adhesives, without a doubt, there's going to be different recipes in these universal adhesives. Each company is going to do something a little bit
Yeah.
different. Whether it's increasing its hydrophilicity, whether it's reducing the amount of air thinning time, because again, something I personally didn't really understand or really focus on is air thinning, and these solvents have to be evaporated from that hybrid layer so that it doesn't disrupt the polymerization process and it doesn't affect the subsequent resin also. And again, so good studies have shown that when you air thin for 10, 20, and 30 seconds, there's always an increase in bond strength, and the sweet spot is 15 seconds. I mean, it can increase the bond strength up to 8 to 10 megapascals. And
Oh, wow.
in the world of adhesive dentistry, we'll take every megapascal possible because that's what we're relying on, right?
That's right.
And so, I'll jump onto that. And so 15 seconds I've been air thinning. And so I think the best clinical recommendation that can be made here concerning the universal adhesives, regardless of the manufacturer, whatever is defined that you're purchasing and it says universal adhesive, again, selectively etching the enamel, be as selective as possible as you can. Just think about over etching the dentin is going to deprive it from the minerals, and it might increase the chances for postoperative sensitivity. So using a high viscosity phosphoric acid as selective as possible as you can be. And then kind of rinsing inside out your cavity, okay? And then that way you can avoid overexposure of the dentin to phosphoric acid. And then you're coming along with your, so now you have a self-etching primer and the adhesive in one bottle, right? And so, I probably, because I've, again, since I've really learned about these materials, vigorous agitation, right, to allow it to penetrate as to the best possible. And then you're going to follow that up with air thinning, right? And so I still do 20 seconds of vigorous agitation. If the manufacturer is going to tell me to do 10, I'm going to be like, well, I appreciate, again, the effort and the technology, but again, show me the long-term evidence on this. We don't have that. Okay. But then I'm going to say, okay, I'll still work with you here on this. I'm going to apply it with vigorous agitation. 10 seconds is not going to make a difference in your practice, right? And then the air thinning process. Even you tell me you don't have to air thin, you can air thin for 5 seconds. Again, 15 seconds. To me, it's not going to make a difference. But I will, after air thinning, go back and apply another layer of that. Again, in my image of looking at that scanning electron microscope of the hybrid layer, all I'm trying to do is just increase the thickness of my hybrid layer. And for me, if you ask me as a clinician in a busy practice, if you ask me to do 2 layers, I'll do that. I know if you do 3 layers, it's going to be even better. But let's be realistic, okay? Who's going to sit there and do that bonding protocol for more than a minute, right? So again, universal adhesives, I think they have very, very good, stable chemistries, okay? I can list 5 manufacturers that have phenomenal adhesives, okay? The differences between them might be very minimal. It's how we apply it that's going to be more important. So selective etch, I do the vigorous application for 20 seconds, air thin for 15, apply another layer of that, and then air thin, and then I'm going to light cure. I think by that, you're really going to enhance longevity of your bond to the dentin surface.
That's excellent. We've done some studies at Dental Advisor. So certainly those of you listening, check that out too. We do a lot of independent research on these materials, especially, what we've just been talking about. And we've got some great data to show just exactly what Dr. Sulaiman has said about where the failure rate is really going to be at the tooth level, not at the adhesive level, because of where we've come in materials. So with that being said, we could have these awesome products, and if we don't use them correctly, that failure is going to be on us, right? Well, this was wonderful.
Absolutely.
Thank you so much for joining us today. And, for this information and so much more, please check out Dental Advisor's website, www.dentaladvisor.com. We have other podcasts. We've got journals that really go deeper into these subject matters. And you can really also take a look at what we do as far as our product evaluations, more research and things like that. And we certainly are happy to have Dr. Sulaiman and his contributions to our team. And so
Yeah.
thank you so much for joining me
And,
today.
well, absolutely, Dr. But it's always a pleasure anytime I get a chance to chat with you, of course. But
Likewise.
I did want to add one important thing
Sure.
because you had mentioned about the issues with the dental advisor coming out and the previous issues as well. One of the most reliable resources that I have found over the years searching the literature, and then when I can't find things in the literature, I go back to things like reports from the dental advisor, and I
Thanks.
would find and then what really sparked my interest more and more about reading these reports is that for the high quality of research that they've been doing in the lab behind the scenes is just on another level. It's phenomenal. And the reports that come out allows us to see testing of materials that we don't have time to look at every single material.
Right.
And so, when we do studies, we might find one or two, in that category. Journals don't like to see you compare between products. They feel like it's a commercial for the manufacturer versus the actual science of it. But, sometimes I say, wait a minute, all of these different, I can list you 10 composites right now of bulk fill. And I'm like, who's going to sit there and test all of them? I
Right.
tested one or two and I came to my conclusion based off of that. But I'm thinking about some of the clinicians that are not using this product or maybe don't even have access to it in their country, for example,
Yep.
who's going to look at. And so again, going back to something like the dental advisor, and I'm like, oh my God, they've already compared all of these products and they're showing me the outcome here. That's just going to save me a lot of time. I don't really have to, again, putting my research hat, I'm like, I don't have to look into these materials.
Yeah.
Reliable research on many of the products. I can't think of they've excluded some adhesive or some composite, some impression material, whatever it is. They've all looked into it. And so it's really been a wonderful resource. And I think it's just only going to get better now with having discussions more about the reports, whether it's a podcast, whether it's on social media. I truly believe it's going to become phenomenal. And, I always encourage the dental students, when you're lacking resources in the literature, or you think the literature is too extensive or too boring, you hear that all the time. No one really wants to look into papers, and papers are very difficult to read and understand. I said, look, pull up something like the Dental Advisor and see how beautifully it's presented, very easy to understand, and visual effects are very easy to capture in your mind. And I think it's going to be, a household name for many of our clinicians to in the future. And I just really admire all the hard work that they put in, and the high level of clinical and scientific evidence is it's just on another level. I love it.
You said it better than I could have ever said. So it really is true. They've got, over 40 years of the research and data and publications.
Absolutely
I
beautiful.
mean, it's just a wonderful resource. So yeah, definitely check us out. Thank you so much for joining us today.
Absolutely, my pleasure.
Yeah, this was wonderful. I always love to like you said, have a chance to be able to chat and go get in the weeds with a lot of this adhesive stuff. So thanks
Yeah,
everybody. Again, be on the lookout for that publication on the principles of adhesion and bonding. Again, thanks for listening to Disruptive Dental Science, and go check out Dental Advisor, and Dr. Sulaiman, thanks so much for joining and being part of the team.
absolutely. Thank you all. Stay safe,
Thanks
everyone.
everyone.
Thank you.